and welcome to Deuk Spine Institute, live stream spine surgery. I'm Dr. Deuk Majin, one of the founders of our company. Today we're going to be treating a patient who traveled here from Kansas. And he's had a fusion in the past at L4-5, not done by me. We'll look at that in a moment, but I can tell you it was obviously unnecessary, as most of you know, in my opinion. We can now fix disc problems that fusions are done for using the laser surgery. But as a result, he's developed adjacent segment disease above and below. So we're going to go in and try to fix that. I've already given him some numbing medicine. He's having had pain for the last 9 months, shot. And I may have to make 2 incisions, which would be normally I try to get everything done with 1 on each side, but because of the alignment of the discs, and really, to be honest with you, the fusion he had done, they fused him straight. If you look at the fusion there on the x-ray, his bones are supposed to be curved backwards, but they're straight. And that's because the surgeon did not take out the abnormal facet joints that are in the back of the spine. If you take those facet joints, and you can see where the facet joint is, right where I'm passing now with my needle, it's abnormal. It's about 3 times bigger than it should be. Those sclerotic facet joints block the surgeon from reducing the spine into lordosis, which is the proper curvature of the spine. Shot. And because they're blocking the surgeon from achieving lordosis during surgery, the patient wakes up with a flat back. And that's what this patient has, a flat back deformity at L4-5, where he's got a straight spine. Well, that then over time causes adjacent segment disease to accelerate. AP? Num. Here it is. All right, perfect. So, let go. I'm just giving him a little numbing medicine here. All right, so we are in excellent position, shot, with the left needle. I'm going to enter his tear. Now people say to me, don't you do damage when you enter the disc? The answer is no, because we're already going through part of the disc that's already been damaged. We're not creating additional damage, we're going through the damaged part. So we don't create any more damage, we use the existing damage as our entry point. Pretty smart. But other types of surgery, to be honest with you, like microdiscectomy, laminectomy, they create new damage in the patient that didn't exist before. All right, I'm encountering some resistance, and what I'm hitting here is actually a bone graft, which from his prior surgery. So it's a little bit higher up than I expected it, but it's fine. We're going to go in a little higher to avoid it, if we can. Shot. I got to get around this bone graft to get to the disc. Shot. All right. Let's see if we can do this. Shot. So it's just another one of the problems we see with people getting fusions is that the fusions they not only cause problems down the road at adjacent segments, but they also affect the surgeon's ability to do surgery at the adjacent segments because of all the scar tissue and bone graft. All right. Any questions, Henry?
At this moment, no current questions.
Let's show the audience then how is it that a disc injury can cause so much pain. And actually, you know what would be nice, Henry? I think we have a new video, don't we?
Yes, we do.
30 causes of chronic back pain. Folks, we're going to give you a treat today. We're going to show you a hot off the press publication that we created at Deuk Spine based on our analysis of our patients with chronic back pain. And we're going to show you what are the most common causes of back pain. Chronic back pain. I'm Dr. R. Deuk with the Deuk Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Deuk laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Deuk plasma rhizotomy of the SI joints offered at Deuk Spine or Deuk Joint Institute. The fourth most common cause of chronic back pain is a piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Deuk piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Deuk. Thanks for joining us. I hope you enjoyed that video. That is one of our newest productions from Deuk Spine Institute that basically capitulates all of our data from 20 years of treating patients with back and neck pain, and we looked at what is causing patients' back pain when they have chronic back pain. And we found that, as you can see from the video, the most common cause of chronic back pain is the discs. Now, discs get injured, AP, and they get injured through trauma. And when you have a disc injury, it can really hurt. It causes horrible pain in the back or neck. And, oh, look at that. Or look at that. We'll just stay there for a second. Yeah, you can go back to Alado, but stay on that picture. Jordan, show us the massive fusion. It's called a bone mass or fusion mass. Look at this block of bone. This is normally not there. That was put there by the surgeon to get the bones to fuse together. And you can see how my needle is glancing off of it. So it is definitely affecting my access to the 5-1 disc. I'm going to see if I can still get around it. I may have to start a little bit lower. Ooh, now I'm hitting the iliac crest. Shot. So really having some issues because of I'm getting wedged between the iliac crest and the bone graft from his fusion. All right. Yep, I'm running into dead ends. Let's see if I can find a way. The good news is if I can't do it on this side, I've got the other side. Ooh, I might have something. I think I might have it. Let's see. Oh yeah. Oh yeah. As I said, it's better to be lucky than good. Shot. Let's see if we're there. Give me an AP. Yeah, we're awfully close. So you can see my tip of my needle is just lateral to the L5-S1 facet joint, which is where we want to be. Let's see. Shot. We might actually be able to make this work. How is he doing? You okay?
How you doing, my friend? You said
Where do you feel that?
Where are you feeling that?
Where do you feel that? Shot.
Right hand.
Your hip? Oh man. I can't believe we got it. Yeah. Shot. Where do you feel it? Huh? In your back? Interesting. AP? All right. I'm going to ask you a few questions, then we're going to put you to sleep and finish your surgery. Yeah, I think that's glancing. So take a look at the needle on the left at L5-S1, folks. All right, we're talking about the disc below the fusion. That needle, follow it, it goes past the facet, show the facet. Yep, and then it keeps going and it goes into the disc, right, through the tear. The one on the right kind of hits the facet and it's getting pushed not into the disc but lateral to the disc. So I have a bad feeling we are not in the disc on that one, unfortunately. Shot. So I'm going to have to try again. If I can't get this side safely, shot, then I'm going to forego this side. It's really important that we don't hurt the patient when we do treatment. It's not worth it because I can't get in. We've got good access on the left. We're just going to treat the left. So I tried to do the right at 5-1. We're aborting L5-S1 right side. All right. How long have you had your back pain for? 9 months. And, all right, L3-4. Are you comfortable right now? Any pain? No? How bad is that on a scale of 1 to 10? 10? Is that where you get your back pain? Good news, we're going to fix that for you. Folks, take a look at that x-ray. Jordan, show us. Henry, go to the x-ray.
Copy that.
Okay, you see this black dye that we injected that used to not be there?
Yes, we do.
Okay, look at the size of the tear in the back of the L3-4 disc. It's massive. The black dye fills the tear. Okay, there should be zero tear, should be zero dye there. That's where his pain's coming from. He's got a huge herniation. So we're going to clean that tear up, get rid of the herniation. That will take his back pain away. Is it better now? Yeah. We did an evocative discogram. All right, how bad is that on a scale of 1 to 10? 10. Is that where you get your pain? Okay. Good news, when you wake up, that pain will be gone permanently. Great news for this patient. We've identified that both discs, L3-4, L5-S1, which I believe based on his physical exam, because he had pain here and here, mostly down here, it turns out that both discs are causing his back pain. And he said that that's his typical pain. That's why we call it concordant. It's a question we always ask. And the results of surgery of this type, when a patient has concordant back pain, is highly successful. Usually around 99.6% elimination of pain at Deuk Spine. Now I want to point out we did the dye injections on the left, but if you look over here, there's dye here too, right? How is that possible? That's because the dye injected on the left went through the tear in the disc and came out the right side. Okay? Pretty cool. As a matter of fact, when we get in here, you're going to see that the needle from the other side, we're going to see it inside the disc. Any questions, Henry?
I believe so. This is either a question and or a comment coming from Judy on Facebook.
Judy on Facebook, welcome to our live stream.
Saying, explained some things about a fusion. I don't know if that they're asking to explain some things about a fusion or...
All right, fair enough.
Yeah.
Judy, we don't know if you're just making a comment and you're happy that we explained some things or if you want us to explain some more. Happy to do either one. What I can tell you about his fusion is it's solid. You can see it's solidly fused on the x-ray, and there's no failed fusion there at all. He fused on the sides, which is called a posterolateral fusion, intertransverse technique, but he's also fused at the inner body. Show us the inner body. Look at the arrow. No, that's not the inner body. There. Show that whole area where the cage is. That whole area is fused. The bone above to the bone below. That's L4 to L5. And then in the back, where Jordan was showing originally, that's the posterolateral fusion, the one that you saw, the big block of bone. So the surgeon did the right surgery. He fused between the bones, the vertebral bodies, called inner body fusion, and he fused intertransverse in the back. He did a combined anterior posterior fusion. That's the best. That's what I do. However, the surgeon did not do the proper technique of correcting the alignment of the spine. Okay? So, spine surgery, all spine surgery done in the world should have 3 goals. The 3 goals of spine surgery, besides the obvious of keeping the patient alive and avoiding complications. Number 1 is decompression of nerves and spinal cord, basically decompression. Number 2, realignment. And number 3, stabilization. Those are the 3 standard goals of all spine surgery. Not every surgeon knows how to do those 3. Not every surgeon does all 3. But the best surgeons in the world make sure all 3 are achieved. This surgeon did the fusion or stabilization part, but they did not do the realignment part. And the reason is simple. They did not do osteotomies. You need to do what's called a Smith-Peterson osteotomy. It's where we cut the bones, the facets out in the back. Because the facet joints get so full of arthritis that they prevent the patient's spine from going into lordosis or curved back. And is that our picture?
Yes, sir.
Take it again. And so when I do fusions, I always take the facets out. I even published a paper on that. As a matter of fact, I think Arias and I published the paper on that. And it talks about how we get really good results with spinal fusion in the back when you do the osteotomies. But Deuk laser disc repair gets even better results. I think our average back pain relief on that paper was 85%. With Deuk laser disc repair, it's 100%. And that's with disc pain, of course, not other types of pain. Just disc pain. All right, any other questions?
At this moment, no current questions.
So folks, we're starting here at L3-4, and we're going to show you why is it that discs, remember the video showed you 30 causes of back pain, but we didn't talk about how the discs cause back pain. So Henry, let's show the audience how do injured discs cause so much back pain for patients.
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals.
Welcome back. And after that, watching that educational video, you can see that the reason people get back pain from an injury to their disc is because of inflammation. Inflammation is your body's system, inflammatory system, attacking what it considers to be the foreign body or foreign invader, right? Think about it. If some foreign country suddenly showed up on our shores trying to invade the United States of America, our military would be there to greet them and to defend our country. Okay, so it's a defense system. The inflammatory system is a defense system, but it's a very old defense system. It's one of the oldest defense systems we have, and it's not discriminatory enough, and it actually sometimes attacks its own people or its own, body. So what happens is the nucleus here, these little pieces I'm working on right now, they're normally that was the needle. You guys see it right there?
Yes, we do.
You see the laser fiber, and just behind it is the tip of the needle. That spark was the laser energy being delivered to the metal of the needle. And is it okay?
Yeah.
All right. So sometimes what happens is I'll hit the needle. Show us the needle, Luis. Push it in. Push it in a little more. All right, you guys see the needle right there?
Yes, we do.
All right, sometimes the laser will hit that, and it'll melt the two pieces of metal together in the needle, and we won't be able to take the middle out. And it's basically welding the metal. And I laugh about people who say, oh yeah, the laser can't remove bone spurs. Well, the laser melts steel with just one blast. What do you think 100 blasts would do, right? Yeah, we can get rid of bone spurs quite easily. That's just people who don't know anything about lasers talking about lasers. When they say lasers can't remove bone spurs, they can. Lasers are very safe when they're used by a surgeon who knows how to use a laser properly, like our surgeons at Deuk Spine Institute. You can't trust any surgeon to use a laser. You have to go where they're used all the time, like Deuk Spine Institute. All right, see all the blast marks there on the metal? Every one of those areas is the laser energy hitting it and melting it. So you could tell we've had this tube used for a while. But this is the tear that we're cleaning. This is where the inflammation happens. And like I was telling you earlier, the inflammatory system, it can't really always pick the right things to attack. And sometimes your inflammatory system attacks your own body. Examples of that are, Sjogren syndrome and rheumatoid arthritis, vitiligo. That's where your inflammatory system attacks the cells in your skin that produce melanin, and your skin will bleach in certain areas where the inflammation is happening. So the same thing happens in the disc, right? Your inflammatory system is attacking the herniation, hoping to get rid of it. The problem is the inflammatory system can never get rid of the herniation. It's too big. It's like you trying to lift up a house by yourself. Sure, you might try, but you can't do it. And the inflammatory system doesn't know any better. It's not smart, doesn't have a brain. It's very old. It's like literally thousands and thousands of years old. So it's just doing what it was evolved to do. Unfortunately, by attacking your herniation, all it does is make back pain and leg pain, but it doesn't actually fix anything. So patients end up suffering every day with that attack going on in their lower back. So what this surgery does is we go in and remove the herniation, we clean the tear, and that way your body can actually heal it and the inflammation stops. So in this patient, he had the same problem at L4-5, but he had a fusion done because he didn't know about us at the time. And then he started getting problems afterwards with adjacent segment disease. And so we're here today to treat his adjacent segment disease. And fortunately for him, he found us. Now look at that. That's the tear. See the annular fibers, how long and white they are? And then they come to the middle of the annulus and you got this blue stuff. The blue stuff is the herniated disc that's stuck to the white annular fibers from inflammation. And those tear is in the middle. So we're going to go and clean the tear. It's called annular debridement. And Deuk Spine Institute and the Deuk laser disc repair procedure, we're the first in the world to do this. We're the first in the world to publish it. Nobody else has published it but us. And it is the most successful treatment in the world for back pain. Our average pain relief is 99.6% for disc pain. Disc pain. All right, Henry,
Yes,
let's
sir.
show our audience how the Deuk laser disc repair actually works.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Okay, we just pulled this piece of herniation out, and it's a pretty good one. You see the red-brown color? Louise, show them. Yeah. That's inflammation going on in that herniation, your body attacking it. That's evidence of inflammation. So I grabbed it out with the grabber, and we're going to take out a bunch of pieces like that. That's not the only one. Most disc herniations have about 30 pieces of herniation on average, is what I found. Some of them are small, some of them are big, but it's around 30 pieces. And that's because in a lifetime, people tend to herniate a lot. Okay, look at that. You guys can see the tear quite nicely. You see the annular fibers coming off the end plate right there. That pinkish stuff, that's bone right there. You guys see the bone, the smooth, kind of weird surface?
Yes, we do.
And then you got all this inflammation going on that's associated with the tear. Okay? And this is a piece of herniation. And my job is to clean this stuff out so that this area will actually be able to heal now. Because this herniation right here that I'm taking out with the laser, the blue stuff, this is keeping the disc from healing. And this is keeping the inflammation going. So if we get rid of it, the inflammation goes away, the disc heals, the patient's symptoms go away. We'll take the questions.
This first question coming from Rita on YouTube.
What? No, really? Rita has a question? I don't believe it. Hi, Rita.
Rita asked, what happens if you have a lot of curvature at the same time as the disc injury and tears? And do you do something with the curvature too? With a lot of arthritis as well?
Yeah, Rita, we don't do anything with the curvature unless it needs to be dealt with. The curvature doesn't cause symptoms. Now, of course, if your curvature is really big, like a 45-degree angle or bigger, then and it's progressive, then maybe we want to do something about the curvature and fix it. And I can fix curvature. It requires fusion with osteotomies, okay? But most people with curvature don't need it operated on or treated. Just leave it alone. That's curvature is not causing symptoms.
Next question coming from, this is, I believe, seeking for advice coming from George on YouTube.
Sure, George.
Saying, hello, doctor. My name is George Franco. I was diagnosed 2 cervical spine straightening, 3 mild marginal osteophyte formation, minor protrusion at C5-6 without canal or neuroforaminal stenosis.
Yeah. What's he asking?
I believe this is Andor seeking for advice.
Okay.
Yes.
George, my advice to you is to do our free MRI review so I can look at your MRI, make my own opinion about what's wrong and what needs to be done to fix it. I don't rely on other doctors' opinions because they're wrong 95% of the time. The problem is I don't know which 5% are right. So I have to just look at it myself to figure it out. That's number one. Number two, when I do the MRI review with you, I'm going to be examining you to see where are your symptoms coming from. Are they coming from your spine or not? Are they coming from what part of your spine? So all of that I can do, and an MRI doesn't tell you any of that. So that's what I would recommend. Do the MRI review. All right, we're cleaning up the annular tear with the laser. The laser fiber, for reference, is 1 millimeter. 1 millimeter, that's the clear tube or the clear fiber. That's what's transmitting the laser energy. It uses differential properties in the index of refraction of the materials, you know, water versus glass. And the light basically just bends at the glass water or glass air interface. And that causes the electromagnetic radiation to change direction and stay within the fiber until the end, and then it's released right out at the end. It's easy to bend electromagnetic radiation using an optical fiber because you have different indexes of refraction for the different materials. But it can't bend electromagnetic radiation at 180 degrees. So a lot of it's going to come out the end, and that's what we want. So physicists and engineers have used these properties of physics to create such instruments that we can use in medicine. Next question.
Next question from...
Almost done here, by the way.
Next question from Lanu on YouTube.
Hello, Lanu. It's been a while.
Asking a marketing question. Video live stream is a great strategy in the marketing world. Do you allow viewers to share all the past live streams to others?
That's a great question for Henry.
Let me answer that, please. I say it is an amazing thing that to share all of our past live streams to others. And the thing is, with live streams, and sharing in general, when it comes to that, unfortunately, when trying to share a video for so long, it eventually just dies down on just sharing it all. Not giving it much of viewership, but at the same time, it gives you more of a strategy and leeway to encourage audiences to watch your videos more and all that. So given that, we do emphasize sharing, but not as much as we should, and I definitely want to work on that more. So thank you for pointing that out, Lanu.
But is that something we have control over, whether a past live stream can be shared on YouTube?
100%. I mean, like, there's a share button on every social media outlet that we use. And
Oh
so,
yeah, so we do allow it.
yeah, well, of course.
Now, is she on, is Lanu on Facebook or YouTube?
This is YouTube, Lanu.
Okay.
Yeah.
Lanu.
But I encourage sharing every time ever. I think we should just emphasize it more. And so thank you for pointing that out, Lanu.
Yeah, thanks, Lanu. All right. Any other questions?
Yes, next question coming from Rita, once more on YouTube.
By the way, I'll just say we're at the end of the disc, at the end of the tear, at the end of the herniation. We started in the inside. It's called the inside-out technique. It was developed by Dr. Anthony Young. He was one of my teachers, taught me this technique with the endoscope, not with the laser. And Dr. Young believes in the inside-out technique because it's safer. And I find it to be the best technique. All right, there was a lot of herniation here, and we're almost done. All this stuff was pinching on his nerves, causing his leg symptoms. I think his leg symptoms will be gone now.
This next question coming
Come on,
from
guys. Can't have that kind of stuff happening. Sorry, Henry, go ahead.
No worries. No, this next question from Rita, once more on YouTube, asking, does that floating tissue show if the knee or back or ultrasound, MRI, CT, X-ray? I think since I'm not healing on a little open cut, they say I won't heal, high risk, been trying to not get infected.
Well, I understand with your condition, the autoimmune disease you have, that you are at higher risk with healing, but you should heal just fine from our surgery. Okay? We have the least invasive, smallest incision, and I've never seen a problem with it healing, ever. So, all right, we are done here. We're going to move on to the next disc. We just finished left 3-4. We're irrigating, getting all the little other bits and pieces out. I put a little antiseptic. Standard for surgery. Surgeons use antiseptic in their irrigation to reduce the risk of postoperative infection. Standard protocol. All right. Let's get this out here. And we are going to have to make a separate incision for L5-S1 because the angle of the discs is completely off and they don't converge at the skin. So I have to make 2 incisions on the left. We're also going to have to do an incision for the rhizotomies. This patient is having facet joint pain as well, below his fusion. So let's talk about that for a moment. You've all heard about adjacent segment disease. Adjacent segment disease is the term given to problems that develop in the joints next to a treatment done on the spine. And typically that treatment is a fusion treatment, but it could also be artificial disc. And what turns out that adjacent segment disease is very common after fusions and equally common after artificial discs. The whole selling point of artificial disc was to avoid adjacent segment disease, but it turns out that artificial discs have the same rate of adjacent segment disease as fusion in a recent study that was done about a year ago. So the artificial disc companies that sell these metal implants have duped everybody into believing the adjacent segment disease rates are lower with metal discs than they are with fusion. Turns out they're the same. That said, adjacent segment disease can be avoided completely if you don't have either, if you have the Deuk laser disc repair. There are no adjacent segment disease cases with Deuk laser disc repair. But what is adjacent segment disease, really? Is it affecting the disc above and below, or is it affecting the facet joint above and below? Actually, it turns out it could be either. It could be an effect on the disc, as this patient has, or it can be an effect on the facet joint, as this patient has. Some patients get both disc problems and facet problems. Want me to wait? After their fusion. Shot? So this patient has both disc and facet pain after his fusion. That's why we have to fix both. Hold on. Yeah, okay, good. All right. Remember, we didn't have a lot of room here, but we got in. And I'm glad we did, because this disc is a 10 out of 10. I mean, sorry, was it 10 or 8? 10. 10 out of 10 in pain. People ask me, why do you use the hammer? The answer is it's the safest instrument to use, given the circumstances. See, if you try to push the tube in with your hand, you could push too hard and suddenly resistance goes away and then you're pushing it in way too deep. With a hammer, or mallet as we call it, surgeons call it, you can control the amount of energy each time you hit it. Any questions?
Yes, we have a couple of questions. This next one coming from Rita once more on YouTube, asking, can the laser also get rid of scarring?
Yes, the laser can get rid of scar tissue. We do it all the time during our surgery. Depends on where the scar tissue is. I'm referring to scar tissue in the disc, within the annulus and potentially crawling into the disc. I'm not talking about scar tissue around the arachnoid, like arachnoiditis scar tissue around the nerve roots and cauda-equina, no. Good question, Rita. Next question, Henry.
Next question coming from Chasen After Jason on YouTube,
Sure.
asking, is this patient having pain on both sides of the L3? I ask because I have the same issue, but pain mostly on one side. How does facet pain present?
So, Chasen After Jason, great question. Why are we doing both sides at L3-4 in this patient? The answer is nothing to do with the pain in his back. It has to do with the pain in his legs. His leg symptoms are bilateral, and the L3-4 disc is herniated on both sides and pinching the nerve roots in the lateral recess between the facet and the back of the disc on both sides. So I had to treat both sides at L3-4 to be sure that I'm eliminating both side leg symptoms. As far as the back pain goes, his back pain is, you could pick a side, left or right usually, and get rid of it. Facet pain, the way we figure out if somebody has facet pain, the key is when they're having the pain, are they having tenderness over the facet joint? And you figure that out on exam by pushing on top of the skin above the facet joint and seeing if it reproduces tenderness. That's for the lower back. For the neck, it's all about rotation. If you turn your neck left or right and you have facet pain on the left or right, turning the left will elicit left facet pain, turning the right will elicit right facet pain. All right, hopefully that answers your question, Chasen After Jason. But I can tell you if you have facet pain with a quick exam. I don't know if you've done our free MRI review, but you should consider it.
We have a couple more questions
I'll take them.
coming from Lanu once more on YouTube, asking, you were studying in Korea before. Has any of your Korean classmates or teachers came to tour the Deuk Spine Institute?
That's a great question. Has any of my Korean teachers or classmates come to tour our center? The answer is no. the truth is, Rita, I don't go out promoting Deuk Spine to other doctors. A lot of doctors self-promote themselves to other doctors because honestly, that's what they like. They like that attention they get from the medical community. I didn't go into medicine to get attention from the medical community. I went into medicine to fix people. And so all my energy is directed towards patients, potential patients, people suffering. I spend my time trying to get people well. I don't spend my time self-promoting myself among my colleagues. A lot of surgeons do. I get it, you know, they like it. That sense of, you know, being a top dog among the colleagues. For me, I really don't care what my colleagues think about me because that's not why I went into medicine. I went into medicine because I care about what my patients think about me, and that's what matters most. So I've not made any effort to bring them here, raise awareness about Deuk Spine to them. They have their own busy lives, and you know, it's not really like Hogwarts where the professors get really interested in the students' lives. I think a lot of these professors do what they do because they want the attention for themselves. And we all know about that kind of person, right? I'm glad that those people exist because we need them, but I'm not one of them. Oh. Okay, I'll admit to you, there was a time in my life when having my peers' adoration, interest, and respect was very important. Like back in high school, you know, running for student government, and college, same thing. But I guess I've outgrown it. I've had to become a scrapper in life. I lost my father at a young age. I had no financial support, and I had to find a way to be self-sustained, and it turned out that all the people you think are your friends, well, there's only so much they can do to help you. You really got to help yourself. And oh, look at that, folks. Inflammation. Beautiful inflammation. That's why we're here. That's perfect, Henry.
I can take a photo.
Yeah, you want to?
Doing that
Get
now.
a quick screenshot. Look at that. That's absolutely gorgeous. Right in the crack. Oh, look at the fat coming out of the inflammation. That's because inflammation uses so much energy, it needs fat. Look at the individual fat cells. How cool is that? Little globlets of fat. That's the energy needed to drive the inflammation that's causing his pain. Tell me when you're done.
We're done. All good.
That's amazing. This is the source of back pain, folks, right there. You get to see it with your own eyes, and I get to take it away. The laser makes quick work of that area, debridement. I always like it because those nests of inflammation are always here, but we don't always get to see them so prominently, right? It's kind of like scuba diving and then seeing a great white shark next to you. I mean, you don't really want to see a great white shark next to you when you're scuba diving, but if you get the opportunity and you get to live to tell about it, it's quite an exceptional experience. We all know there's sharks down there. We just don't see them all the time. But when you actually get to see one up close and personal, and you realize what a incredible opportunity it is, it's something you never forget. Questions?
This next question coming from Rita once more on YouTube.
Is he moving? Okay, I'll take it.
Rita asked, I just tried to get the person in Europe. They wanted to know how to see wanted to know how to see you live. They're 8 hours ahead. I said, I think if I see you, see you live, they should too.
Yeah, I'm live right now in Europe.
Live, excuse me.
Yeah, I'm live in Europe right now, Rita. They should be able to see us. They just have to go to the Deuk Spine website, www.deukspine.com, and there should be a button that says Watch Live Spine Surgery, and there's only one way they would not be able to see us, and that's if our website is blocked in their country, which I don't think it would be, but I'd love to know if that's the case. All right, we're just about done at L5-S1, and I am really happy. I was not able to get to the right side because of the bone graft that was there from prior surgery, and the facet joint was pushing my needle away, and it would not be safe at all for me to proceed. I could hurt the patient badly. So I chose to abandon the right side at 5-1, but the left side turned out to be the right thing, and I think he's going to do really well. We have one more to go, and then we're going to do his facets. His facets will be quick. Then we have another case after this. That patient is a bilateral L2-3, DLDR, and DPR. Yeah, and then the last case is a 3-level lumbar deal with DPR. Then tomorrow we have a light day with 6 surgeries. Oh my God. And our patient is first patient is from Singapore. She's here with her husband because she did her research and she wants the best in the world to fix her neck. And that's what we're going to do. So we'll start out bright and early tomorrow with a Singaporese patient with a cervical DLDR and a cervical DPR.
We have a couple more questions.
Sure, I'm going to take the grabber and we should be done here.
This next question coming from Wanu once more on YouTube,
Hi, Lanu.
asking, how was your experience studying in Korea? Any language barrier?
Fortunately, the Koreans are well versed in speaking English. I could not speak Korean, but the course was taught in English. And Dr. Seng-Ho Lee and Dr. Gun Choi both spoke English, albeit, broken English, but it was good enough. The nice thing is that with surgery, there's not a lot of speaking. It's a lot of doing. It's one of the reasons I went into surgery. I don't like talk. I like action. I'm an action kind of guy. And so, the words were few. There was a lot more nodding of the head and smiling and gesturing than words. But, we all know what a needle is. We all know what a scalpel is. We all know what an endoscope and tube are. So we spoke you've heard of people speaking the language of love. We spoke the language of surgery. And surgeons understand the language of surgery quite well. You just have to see how to do it. Great question. So no, I don't think the language barrier was a problem. I didn't make friends with them. They probably wouldn't even be able to pick me out of a lineup. They probably don't even know who I am. But that's okay, it doesn't bother me. I don't do what I do for recognition from my peers. I do what I do for recognition from my patients. You like that one, Berndes? That's a good one, isn't it? I like that. Jordan? All right, yesterday we were talking about donuts. We got to find out everyone's favorite donut. Boston cream. All right. Yeah, where is Davis with his Boston cream? So today, what should we talk about? We have any questions?
This next question is coming from Tracy on Facebook.
You ready? I'll take Tracy from Facebook's question.
Asking, what might be the symptoms of an L5 nerve root compression?
Symptoms of an L5 nerve root compression would be numbness in your leg down to your ankle or foot, weakness with picking your foot up from the ground, like cocking it up off the ground, difficulty walking because of weakness. You could even have some pain maybe going down your leg, but mostly numbness and weakness. Good question. Needle is out, guide wire left. Bringing the dilator down. The dilator is cannulated, meaning it has a channel inside of it that allows me to inject some numbing medicine so our patient can be a little more comfortable during the procedure, along with the anesthesiologist stuff. Let's go, Jordan. Keep taking them pictures. All right, let's do it. Favorite Aliens movie? Let's do it. Who wants to go first? Random. Berndes.
Yeah.
Favorite Aliens movie?
Just gonna go with the alien movie.
The first one.
Yes, the first was done.
That's your favorite. You didn't like Vasquez in the second one? All right, fair enough. It's a great one. Jordan? Alien versus Predator. How did I know? Jordan, Alien versus Predator. Henry, how about you?
I really liked Alien vs. Predator, not going to lie, but I'm going to go with the first one, 1979.
Wow.
Yeah, it's a classic.
All right, how about Arias?
He says none of them.
Got to pick one. Can you pull my skirt up? Got to pick one. All right. Luis?
I will say Alien versus Predator as well.
Alien versus Predator. Oh my gosh, we got 3 votes for Alien versus Predator.
Yes, I like
All right, who's over there? What nurse is over there? Kira. Another Alien versus Predator. It's a safe bet, right? Everybody else is voting for it. All right, that's 4 votes for Alien versus Predator. That's incredible. How about you? No, you're not. You guys are all fired. Get out of here. Luis, you already said Alien versus Predator.
Yes,
Oh, my Lord. I say Prometheus. Prometheus. That was pretty badass. Laser. But I also like the original Aliens. Then again, I like Aliens 2. I don't remember 3. I'm going to have to watch it with my family. It's been a long time. All right, Henry, any questions?
At this moment, no current questions. We do have a comment with from Rita on Facebook who says original Alien with Sigourney Weaver.
There we go. There we go. There we go. All right, yeah. Of the movies with that have the word alien on them, I would agree with Aliens, the original. But of the series, if you include Prometheus and Alien vs. Predator, I like Prometheus. So Rita, if you haven't had a chance to watch Prometheus, you should. It's incredible. Yeah, but it is more sophisticated too. Like just the whole shooting.
With the famous actor, Prometheus and the famous actor.
They had a few. Not Anthony Hopkins.
Yeah, he started it.
No, was he?
I think he started
Maybe you did. I don't remember. Oh, no, there was a guy, the old guy. But you're thinking,
Who started Prometheus? Was it Anthony Hopkins?
I don't think Hopkins was in.
I don't think Hopkins was in that, no.
You're thinking of the one with the spaceship and the big alien, right? Maybe there's a different Prometheus. Maybe you're thinking of an old one. I don't know. All right. Well, Henry, let's show our audience, because we're going to treat the facet joints next. Do we have a video on lumbar facet pain?
Yes, we do.
Let's show them how do facet joints cause pain.
Copy that.
Thank you. All right, welcome back. So you can see that facet joints are another type of joint that gets injured, and they do cause back pain as well. Facet joints cause a large portion of back pain. They're the second most common cause of back pain. But as the primary cause of back pain, they are 8%. Now, as a secondary cause of back pain, they cause back pain in 50% of patients with chronic back pain. That's a lot. So if you've had back pain for more than 6 weeks in your life, there's a 50-50 chance you've got facet pain, along with probably your disc pain. And we're going to need to treat both, like this patient. This patient has two problems. He has disc injuries and he has facet injuries. So we're fixing both today. And when I say fixing, I don't mean, people sometimes get the wrong impression of what fixing means. It doesn't mean we're going to make his discs look normal or his facets look normal on the MRI or X-ray. It means we're going to get rid of the symptoms from the disc and facets. How are we doing out there?
Sam.
How are we doing? Come on in. Any questions, Henry?
Yes, sir. We have a question from Hugh on Facebook
Hello, Hugh on Facebook. Welcome to our live stream.
asking, what is a pars defect and can it be fixed?
Yeah, great question, Hugh. So the pars is a piece of bone located in the spine, and it connects the, without getting too technical with you, the superior articular process or pedicle to the inferior articular process of the vertebrae. And it acts as a kind of a connecting piece. A defect is where it's no longer intact. And I know that's kind of playing with words, but nobody really knows. And look at this right here. This is just dripping off here. So I need something here, like a towel on it or Raytec, just to keep it from coming out of the bag. Sorry, I'm dealing with a little drippage on my leg, kind of an issue. A pars defect just means there's a discontinuity between the two sides of the pars in the middle. And people used to think it was fractured, but then you look at it, it looks like it's elongated but in continuity. And then they said, oh, it fractured, but it regrew back together. And then it gets longer, so they said it fractured, it separated a few millimeters, and then it grew back. And then it fractured again, separated a few millimeters, grew back. So it gets longer and longer and longer. In the end, it doesn't matter. The pars defect, you leave it alone, okay? I used to tell people they needed a fusion because that's where their pain was coming from. But it turned out it's not true. And it's not that I lied to them intentionally, it's that that's what I was taught to tell the patients, so that you fuse them. And in the end, it turned out after I had patients that didn't want fusion, they had a pars defect, they wanted laser. And I said, well, it's probably not going to work. This was like 16 years ago. And I did it, the laser, and it worked. Got rid of their pain. But I didn't do anything with the pars defect. I left it alone. So I started to realize the pars defect is actually not part of their pain or symptoms, because I was curing their pain, curing their symptoms with the laser, but I wasn't doing anything to fix the pars defect. So everything I was taught as a resident in neurosurgery about fusing pars defects was wrong. And so now I tell people the truth, which is leave it alone. It's probably not causing your symptoms. But what you really should do is do a free MRI review with Deuk Spine and let us make a diagnosis. What's causing your symptoms? Let us look at your MRI. Let us help you by advising you what needs to be done to get rid of your symptoms. Okay? That's the best advice I can give you. Man, that's the tear right there laterally. You can see it's pretty substantial. God bless you. Just about done here. Another minute or two. I had a big herniation laterally there.
We have another question.
I'll take it.
This comes from Mixin' on Up on YouTube.
Mix it on up. Yes.
They asked, I've been told that you are at about 20% high after a discectomy. Does the percentage rise after receiving more and more discectomies? Like I've said, I've had 3 on the same spot. Seems to happen every 4 years.
Are you asking if I agree with the percentage? Because to me, the percentage sounds about right. You're definitely at higher risk after you have a discectomy. But as I told you before, the surgeons you're dealing with don't know how to do what we do. They don't even know this surgery exists. If they tell you they do, they're lying to you. They really don't even know it exists. So if they knew how to do the surgery and they could do it for you, they would do it. Because this is the best in the world for your problem. The problem is they just know how to do microdiscectomy and fusion. So they're going to push you towards fusion at this point. If you've had 3 microdiscectomies, most surgeons would recommend fusion at this point. That's only because they don't know how to do the laser surgery. But because we know how to do the laser surgery, we would recommend this over a fusion. It's much better. I don't know if that makes sense. Hopefully it does. We're done. I got to do the DPR though. There's something here. It may be a piece of herniation. Sure looks like it. I'm going to try to get it out. So we're going to finish with this disc, and we're done with the disc surgery. We're going to move on to the rhizotomy surgery, which is the L5-S1 Deuk plasma rhizotomy. Let me get that laser one more time. Any more questions?
At this moment, no current questions.
Now we're not going to restream with the right. Come on, Nikki. Nikki. It's because you turned it on after I pushed the pedal. You gotta be ready. When you see me grab the laser fiber, that's your clue to turn it on. Can't get distracted. All right, go ahead, Henry.
This next question coming from Rita, once more on YouTube, asking, would knee pain cause back pain and vice versa? And also, can you operate if on a high dose of aspirin? I'm not allowed off HD stroke in 2008. Regular blood thinners gave reaction. 2008 rear hit thigh numb since 2.
So I understand your question. Can I operate if you're still on aspirin? The answer is typically no, but it depends on the type of surgery we're doing. That's number one. More importantly, why are you on aspirin? Hey, did it fault again?
Ready?
All right, I think we're done here. I don't see any more herniation. Same one? Did you ever get the other one checked out?
Yeah, but this one different.
It was a mirror issue, right?
Yeah, the other, yeah. But this one, what is it? Is it something? No. This one, I think it's, if you hit it twice, touch it, I think it's, you know what I'm saying?
Lights on? All right, did I answer the question all the way?
I believe so, yes.
Great. Well, we're finished with the discs. Now, remember I told you earlier, he has not just disc pain, he has facet pain as well. So he's decided he wants to get it all fixed, and I think that was the right choice. We're going to fix his facet. Let me get one more irrigation. Scope use is a 7. Can you move this stuff out of here, please? Like now? Get all that stuff out of there. Uh-huh. Did you say there are any questions, Henry?
One just popped up. This coming from Tracy once more on Facebook, asking, can facet arthritis cause radiculopathy?
Oh yeah, it was the knee and the back. Yeah, to get back to the knee and the back pain. Knee pain cannot cause back pain directly, but you can walk badly because of a bad knee, and you can aggravate things in your back that cause pain. Same thing vice versa. Back pain will not cause knee pain. All right, sorry, I missed the question.
From Tracy on Facebook asking, can facet arthritis cause radiculopathy?
Yeah, it's a great question. Can facet arthritis cause radiculopathy? The answer is yes, it can. 2 ways. One, facet pain can refer down your leg, and you can feel like it's sciatica. Facet pain can go all the way down to the knee, even past the knee a little bit. And some people think that's sciatica, but it's not. So they assign it to radiculopathy, even though it's facet-referred pain. Second of all, facet arthritis can actually get onto the nerve root as it's passing just in front of the facet joint down through the foramen, down the leg, and cause radiculopathy that way. That's the more likely. Remember, facets get enlarged. Are you ready? That's it there. All right, hold on a second. I need pressure here. Tell me when you're ready, right here. All right, we're going to shot. Okay. It's going to be fun. That's one. Make a little incision, and we're going to treat his facet. I don't know if I completely answered the question to your satisfaction. Hopefully I did. Berndes, we're almost done. I've got to do these facets, which will take not too much time. Shot. So the first thing I have to do is get to the L5, which is a little bit to the side here. The L5 transverse process, and where it connects to the superior facet. All right, and it's just below where I'm at. You guys see that?
Yes, we do.
Shot. I need pressure there. Uh-huh. Move. Pressure right here. Give me a second. All right, you see the tip? The tip looks pretty good, because if that's where it is, that's where we want to be. Shot. Yeah, I think that looks really amazing. A lot of scar tissue here. Shot. I'm going to just check my position. Looks good. All right. We're going to redirect and go a little bit south. Shot. Too far south. South means towards the feet, in case you're wondering. Shot. Not far enough north. Shot. It's getting much better. You can see we're very close to where we want to be. Shot. And I will say this. Many people have different anatomy to their spine, but a few things hold true no matter who they are or where they come from. One of them is that this pain nerve, shot, runs right where the tip of my probe is, right there, in every human being on Earth. Okay, so if I can get my probe right there, we can kill the pain nerve. It doesn't matter where you come from, what continent, what sex you are. Shot. None of that matters. In the end, the fix is the same for everybody. That's one of the things I like about what I do, is the consistency in anatomy of human beings. It's quite amazing. It allows me to help people from all over the world because we all have pretty much the same anatomy. This side's going to be much harder because of all this prior surgery he's had done. That's looking really good, but I'm not deep enough. I need to be a little deeper. A lot of scar tissue here. I feel it as I'm trying to get down to the transverse process. Shot. It's very deep. It's the top of the TP. In the area, I feel bone. Shot. Just above where I want to be. Shot. Dr. B, we have about 2 minutes left. All right, one down, one more to go. The scar tissue that we're talking about is from the fusion. He had that fusion done, I don't remember exactly where, but it was maybe in Kansas. And unfortunately, fusions create a tremendous amount of scar tissue around the spine from the surgeon basically getting bleeding and cutting through tissues. Shot. Too medial. Any questions?
Just one question coming from Mixing On Up once more on YouTube, asking: is that pain nerve doesn't regenerate?
No. Yeah, mixing it up. The pain nerve after our procedure will not regenerate, but after an RFA it will. And the difference is the way we do this treatment, it's designed to not let the pain nerve regenerate. What we do differently is we deliver more energy called plasma, which RFA doesn't deliver plasma energy. But also we move the tip around to be sure to get that nerve. Shot. Otherwise, it would regenerate. Shot. Shot. Sorry, it's taken me a minute, but I want to make sure we get this right for this patient. I don't want them having to come back. Shot. All right. That's as good as I can get it. All right, thanks for joining us. You can see that we treated the L5-S1 facets with the DPR plasma rhizotomy. We treated the discs with the Deuk laser disc repair, and I think he's going to do fantastic. He's a pretty tough guy, has a very high pain tolerance, but that said, I think he's going to be much happier because he likes to work his ranch, and I think he's going to be much happier, being able to work without getting that horrible pain. All right, thanks for joining us. We'll be back shortly with another surgery.